Hi, everybody. Today, it's my privilege to introduce Dr. Curtis Elko. Dr. Curtis Elko has, for the last 30 years, practiced as a clinical pharmacist at the Washington Poison Center. There, he helps callers understand and manage drug and poison exposures. Since 2007, he has hosted a Poison Center advanced practicum with more than 80 pharmacy students from the University of Washington, Washington State University, and Creighton University. During this time, he has published dozens of abstracts, including the results of an American Poison Center's Research Award in managing insulin therapeutic errors. In 2021, he began a research collaboration with Washington State University College of Pharmacy investigating the utilization of high-dose NAC for massive acetaminophen exposures. His outside interests include astronomy and long-distance running. It's my honor to welcome Dr. Elko to the Washington Poison Center's Overdose Harm Reduction and Treatment Series. And with that, Dr. Elko, please take it away.
Thank you, Justin. Going to turn off my video so I'm not distracting everybody, but I'll distract you with a lot of other information. And let's see, find my slides here. Okay. Well, thanks again for having me. This is a talk that I am looking forward to. It's a very, very challenging topic, and so I'm going to share with you some recent changes that have come up in the management of acetaminophen toxicity, specifically with the antidote and acetylcysteine. So I am very, very immersed in this problem, and it's very challenging to present this sort of information. So I want to walk you through kind of a historical narrative for this problem, and I want to discuss kind of what led up to all these changes, and then I'm going to look a little bit at, well, what's the information on, are these changes, not only necessary, but are they helpful? And then, I want to show the kind of the process of Poison Center involvement and how we kind of rolled this out here in Washington to help kind of deliver these new recommendations to patients. So this is basically, there's two ways that we administer N-acetylcysteine, the antidote for an acetaminophen poisoning. There's standard N-acetylcysteine dosing, and I apologize for abbreviations, but NAC or NAC, that's the abbreviation for the antidote, and APAP, that's an abbreviation for acetaminophen. And so if you could just keep those two abbreviations in mind, then possibly it'll be less confusing for me to explain it. So we've got two recommendations now, and I think if you practice here in Washington, you're probably a little bit or a lot familiar with these. But so the difference between the two, while the similarity is they both have the same loading dose, the same starting dose that's given over a 1 hour time frame, 150 milligrams per kilogram intravenously. And then there's a maintenance dose. So for the standard dosing, it runs over 20 hours. There's 2 bags. So it's a 3-bag procedure, a loading dose, and then 2 follow-up bags. The 4-hour bag is 50 milligrams per kilogram. That's 12.5 milligrams per kilogram per hour. And then the 3rd bag is 100 milligrams per kilogram over 16 hours. And that's 6.25 milligram per kilogram per hour. The higher dose runs at one rate. So it's a 2-bag procedure. We have the loading dose, and then there's a bag that runs for 24 hours intravenously at 20 milligrams per kilogram per hour. So you can see, obviously, it's a higher rate of infusion, and it goes for a little bit longer. So how did we get to this? So so we're just going to step back in time here and look at some historical information. So going back to the 1800s, and I know nobody remembers that far back, but there was a mistake that was made. They were trying to treat somebody for worms, and they accidentally gave them the wrong thing. So kind of ironically, the era of acetaminophen started with a mistake. So acid analyd was given to somebody. It didn't help their worms, didn't seem to do any harm, but it helped their fever. And so this molecule was identified as a treatment for inflammation, fever, and pain. So it was kind of a interesting accident there. However, it did produce a problem, methemoglobinemia, which is a problem with our blood that carrying oxygen. So it had kind of a downside that it turned people kind of bluish if they had that problem. So they did a little experimentation with the molecule, as people do today, and they determined that phenacetin had the same benefits without turning people blue in their face. And that was great. I mean, we had a pain medication. It didn't cause, any outward symptoms, helped with fever, and that was in around 1913. However, chronically, there was a problem with kidney problems, interstitial nephritis that was kind of seen. So that was definitely a downside to it. And what was known at the time, acetaminophen was around at the time. It wasn't the favored medication, so it was kind of on the back burner here. But what they found is that phenacetin really is metabolized to acetaminophen, and these look like my old slides, and so let me see if I can switch to my new slides here. I'm sorry for the problem there. Okay, these are my correct slides here. Sorry for the interruption here. So let me move over to where we were here. Okay, so before we get into the historical aspect of this, I want to talk to you about how we've been how we've kind of seen acetaminophen and the antidote here at the Poison Center. So this is the data from our Poison Center. This shows over the last 24 years what we've been seeing. So the orange line is all of our acetaminophen cases that have been seen at hospital, and the blue line is the antidote, N-acetylcysteine. So you can see that not everybody gets the antidote. But I think another thing that you can see is that the cases have been increasing over the last couple of decades. And especially looking at 2019, 2020, that was kind of the start of the pandemic. We see definitely a real bump in cases. That during that time, it was a very difficult time, as everybody remembers, but that was also when we were rolling out the new recommendations for the higher dose of N-acetylcysteine. So it was kind of a perfect storm during that time, but we got it out just in time. So what are these cases? So the reason that people take acetaminophen, is really kind of interesting. Mostly what we're seeing are intentional overdoses. So that's the orange bars. That's by and large the vast majority. Unintentional, these include therapeutic errors and toddlers or people with say Alzheimer's, dementia, accidentally taking things. And then there are some cases that are unknown, but these are the two big categories here. In terms of these unintentional events, the majority of these in the past have been the kind of the toddler group, the random events of kids getting into bottles and things of that nature. But you can see that as a percent of our unintentional cases, this is a decreasing problem, and that actually we're categorizing more problems in terms of adverse reactions, in terms of people taking this therapeutically and developing problems. Now then, if you look at the intentional events, the vast majority are suspected suicide or suicidal ideation events. And this really has been the driver of a lot of the increase. Now, what I'm showing you here are just the cases where we used the antidote. So we're not looking at all of the acetaminophen cases, because many of them don't require the antidote. So you can see, a certain percentage do. A lot of these suicidal cases end up getting it. But this is like the big driver of the increase here over time. So in terms of who's taking it, this is the kind of the middle point for age. And these are, again, the antidote cases where we use the antidote. And what you're looking at here, the orange line is the upper 75th percentile. So that 25% of people are older than this line. So this is age 40. And then the lower line, the gray line, is the bottom, down to the bottom 25th percentile. So you're looking at basically teenagers down here. So the middle point are people in their 20s. So these lines represent half of our cases in terms of age. So what we're looking at, half of our cases are between your teens and up into your 40s. So as you're probably aware, acetaminophen causes liver problems, liver toxicity, and that's the main parameter that I'm looking at. So these are the cases of liver toxicity of the cases that get antidote. So you would kind of assume that that if we have a perfect antidote, that the cases would be 0% of our cases should have any sort of liver dysfunction. But as you can see, back in 2000, getting upwards of 15 to 20% of the cases had evidence of liver dysfunction. And then the other thing you can see is that as a percent of our cases, this was increasing over time. Now, the blue line represents the less severe form, where the liver test is less than 1,000, and the more significant one is greater than 1,000. That's the orange line. And again, 2019, 2020 was kind of when we rolled out this new dose of N-acetylcysteine. But I think you can see definitely there's a trend of increasing liver dysfunction in these cases. And this is not really what you want to see so with an antidote. And so this is of concern. The question is why? What can we do about it? And that's really you need to look and see, well, what might be the cause. So this is how we've been using the antidote over that time. Now you can see there's been some changes. Overall, as a percent of all of the acetaminophen cases, there's an increasing use of antidote. Now, I don't think that our recommendation on when to use this has necessarily changed. As a percent, though, we've gone from about 20% up to about 40%. So for some reason, cases are now more commonly meeting criteria for use of the antidote. The other thing that you see is the blue line here. That's the oral N-acetylcysteine. We used to give it orally primarily. The orange line is intravenous, and that's primarily what we're doing today, is all intravenous. So that you might have a question, well, is the decreasing use of oral N-acetylcysteine the cause for the gradual increase in the LFTs? And I think the answer is I don't know. You know, we will be looking at a lot of studies, but I think that most of the studies really have not shown any significant difference for the most part between the two modes, between oral and IV. So here's the other thing that's changed a lot over the last 20 years or so is how we prevent absorption. So if you could prevent absorption of acetaminophen, you wouldn't need the antidote. So we've got two methods. We can wash out the stomach, or we can give activated charcoal to bind up the acetaminophen and thereby prevent the absorption. So back in 2000, the lavage or washing out the stomach was up around 4% of our use, activated charcoal about 7%. Of the acetaminophen cases, but you can see that lavage has really declined to the point of today we're hardly using it at all, and the activated charcoal though has also declined, so that currently in terms of acetaminophen we're only using it in about 3% of our cases. If you look at just the N-acetylcysteine cases where we use the antidote, you're going to see the exact thing, except there's a lot greater use of GI decontamination. Currently, of the cases that require antidote, we're using it in about 8% of those cases. So another thing that's declined over time, and you know, again, is that something to do with the liver function tests kind of gradually increasing over time? Again, I think that's the question at hand. So we have a tool in where we can decide which type of treatment we're going to recommend, whether it's standard or whether it's higher dose. So I'm going to sort of unpack this for you. This is a very complicated tool here for you to look at. It's something that we're very familiar with. We've been using this new tool for about 4 years now. This is a modification of the standard RUMAC nomogram tool that tells you whether you should use the antidote or not. So we're back to the slides that I had left us with. So this is taking us back, you know, over 100 years ago. So basically, acetaminophen was found that phenacetin actually is not the active drug, it's acetaminophen. So when you take phenacetin, your liver metabolizes it to acetaminophen, and that's actually the active drug. So great, there was a solution for this kidney problem. And what they didn't realize at the time was that when they were giving acetanilid and of course phenacetin, you were producing small amounts of acetaminophen with acetanilid and a lot more when you were taking phenacetin. So during this time, we were actually taking acetaminophen. We just didn't know about it. So acetaminophen is then further metabolized in the liver, and there arrives our problem. This is the toxic metabolite here, NAPQI. That's the abbreviation for it. And that's the reason, and NAPQI is produced in the liver, and that's pretty much where it stays. It's very reactive, and it immediately or very quickly reacts with the liver. And that's why acetaminophen toxicity is very focused on the liver. So this is a breakdown of metabolism of acetaminophen. So there are some non-toxic pathways over here. This is the bad one right here, the NAPQI. So the liver has ways of metabolizing it safely when you take normal doses. It's when you take an overdose that you use up or fill up all these pathways, and then you start to produce more of this toxic compound. So when you start to build up this toxic compound, you then cannot get rid of it safely, and it starts to react with your liver, and that's what causes the liver damage. So this is our normal pathway for neutralizing the toxin, the NAPQI. This is glutathione. It reacts directly with the NAPQI, but there's a limited amount of it. And so when you're producing too much of it, you use up all of basically your body's own antidote, and then you start to react the metabolite with the liver. So the N-acetylcysteine comes in, that's the antidote, and it replenishes glutathione. It gives you more of what you need. And then we can give a lot of it and as much as we need to give and produce this glutathione. And the N-acetylcysteine, this antidote, is also said to react directly with the metabolite and restore some of these other pathways. And beyond this, there's multiple mechanisms beyond this, which is well beyond the scope of this with this talk. But this is the idea of why we're using the N-acetylcysteine here. The key here, though, is this NAPQI is very, very reactive. So if you don't neutralize it, it's going to immediately start to react with the liver. So time is really important here. So I'm going to, again, look at a historical perspective here. This is the first cases that were reported of acetaminophen toxicity. This was in 1966. So this was a good 10 to 15 years after the use of it started increasing. So I'm going to show you one of two patients. This patient ingested 150 tablets along with some alcohol. They washed the stomach out, as we don't do very often today. There was no activated charcoal at this time. That was day one. Day two, they developed the classic, that we understand, the classic symptoms: upper quadrant pain, abdominal pain, nausea, a little yellowing of the eyes. And this just went from bad to worse. The signs of the liver failure, low blood sugar, becoming very acidotic, having bleeding problems. This is all very classic in a liver failure. And they do the things that we do today still. We give dextrose for the low sugar, acidosis, you get bicarb, vitamin K for the bleeding, etc. They didn't have the antidote, though. And on autopsy, there was a very classic presentation of centrilobular necrosis. So, what do you do when you see a case that you haven't seen before? Well, and you look for other cases. And if you start to see them, you collect them and you try to understand what's happening. So this was the first kind of presentation of a collection of cases in 1971. So this was during a time in which there was no antidote, there was no N-acetylcysteine. So these were all treated just with supportive therapy, just like we just saw. And these are the outcomes. The solid lines are liver damage, dotted lines are no liver damage. And you can see that the liver damage cases are clustered up here around 300. And this is the acetaminophen level. This is 300 micrograms per mil. This is the same level that we draw today to look for toxicity. So you can see that in these higher levels, that's where the liver damage was happening. And that at the lower levels, you're not seeing the liver damage. And so people immediately started looking at that. Well, hey, can we use this to decide if somebody's going to get sick or not? And so this is where the tool that I was showing you came from, the nomogram, so that a line was drawn, and Rumac brought in some other cases and looked at the outcomes here for liver damage and decided that you could draw a line. And this is the 300 line. This line got lowered for safety to 200, so that if you were above this 200 line, then that was going to put you at risk of the liver damage. If you were below, there was less of a risk. But there was a lot of limitations. Although this 300 line was uniformly hepatotoxic, and we knew that if you were under 120, you weren't going to be toxic. And this is at 4 hours. But these lines, so these lines represent your liver metabolizing the acetaminophen. So at 12 hours still, if you're above this line, you're still at risk, even though you're a lot lower in your level. Because what's been happening during this 12 hours? Well, your liver's been producing that toxic metabolite. So this was really a valuable tool. What we didn't have was anything to do about it at that time. And they also noticed that in liver damage patients, the liver was having trouble getting rid of the acetaminophen compared to people without liver damage. So you can also look at how fast the acetaminophen is being cleared from the blood to see, well, is this patient at some risk? So now we're going to look at the antidote and the production of the antidote. So immediately they started looking for a substitute or something to help the liver detoxify the acetaminophen. This was borne out through looking at animal studies, and they learned, how the liver detoxifies acetaminophen. So basically, they started looking for a way to replenish their glutathione. So N-acetylcysteine came in pretty quickly into the picture. It was well tolerated. You can see here when people's level were 200 to 300, with the N-acetylcysteine, there was no liver damage. When there was above 300, there was one case. And these are the supportive cases where nothing was used. Now, this was not a controlled trial. These supportive cases where nothing was done, that was from the past before the antidote was done. There has never been a placebo-controlled trial for N-acetylcysteine. There's just, safety concerns. We now know that we have a good antidote, and we're not going to test people without giving them that antidote. But this study only considered patients who were treated within 10 hours. So even in the 70s, the researchers understood that you had to give the N-acetylcysteine within 10 hours, or it was not going to be as effective. So what can we learn from this? So we're going to use that nomogram, that line at 200, and this was in the 70s. So this has changed a little bit. And that 300 without any treatment, that's going to be liver toxic. And that you have to treat your patients within 10 hours to be most effective. So the authors speculate here, even then, that could a higher dose of N-acetylcysteine be even more effective? And so they left that as like future research. So a few years later, this study came out. This was in the United States, and this is a study by Rumack et al. And that's the same person who has his name attached to this tool. So this is the 300 line, this is the 200 line, and then for safety, he lowered it 25%, and this is the 150 line. And this is the line that we now say you should get N-acetylcysteine. And it was put there for safety. Now, over the years, different countries and different groups have sometimes used the 200 line, but we're currently using the 150 line. And this line is drawn how many hours after the overdose was taken. So this 150 is at 4 hours. At 8 hours, it's going to be half that, 75. At 12 hours, it'll be half that. So in this study, they were looking at oral N-acetylcysteine. There was no IV version made at that time. And they didn't really report levels, but they reported, well, are you above the probable risk line? And then they looked at how many hours after the exposure did you get treatment. So they were, again, more focused on when did you get treatment than really necessarily exactly how high your level was. And what did they find? They found that if you got the N-acetylcysteine within 10 hours, again, that's the lowest percent of the liver damage. And that after 10 hours, it goes up rather markedly, from 7% to 29% to 62%. So this was really established, this tool, as our method of determining when antidote gets used and for acetaminophen. And we still are using this today with some modifications. And it's worked relatively well, but there are some limitations with it. So they looked at this study, and you could see that after 10 hours, really, and this has just been borne out time and time again, that over time, it's going to be less and less effective. So that when you're getting out 16, 24 hours or more, and the level is very high, when you're above this 200 line, almost half the patients are going to have significant liver injury. And this data came out in the 80s. And I don't think it's markedly changed since then. There's been a lot of studies since then. But I think this has held up over time. And finally, in 2004, we got approval to use the IV form of it. So you would think that, hey, all is good. But then we started getting case reports of failure. Now, it wasn't that we weren't having failures before this, but they might not have been reported. So this was a case of a 78-year-old who took almost 100 tablets of extra strength acetaminophen. So this is a pretty massive ingestion, almost 100 tablets. Charcoal was not given. The 4-hour level was 281. They started the IV N-acetylcysteine. The level came down at about the end of the antidote, and the level was still elevated. And for some reason, they decided, well, the liver function looks good. Well, the patient should be okay. Well, that was not the case. The level went back up at around 50 hours. They found out about this and restarted the N-acetylcysteine. So there was a gap in treatment here. And you can see during this time, the liver function was normal, relatively normal here. These are the liver function tests. And they started really, really bumping up at about 70 to 80 hours out. The outcome was good here. The patient was discharged on day 12. Then in 2009, we have another case. A 48-year-old took 150 tablets, another massive ingestion. So they started the standard course of NAC. And you'll notice that the 4-hour level here, the initial level at least, is only just above 100. So 104. So we might, if that was a 4-hour level, we might not have even recommended it. But they went ahead and gave it, which was a good thing, because the level just continued to rise. So that at 48 hours, the level was really quite markedly high, over close to 500. And you can see that the LFTs started going up as well. And then at the 48-hour mark, they decided to double the dose there. They were giving 6.25 milligram per kilogram per hour, so they doubled it. So this is one of the first cases where a dose modification of increasing the dose occurred. But the patient unfortunately died. Here's another case, a 12-year-old, 175 tablets. We have a level over 600, so very, very significant. They started the N-acetylcysteine. They noticed the level at around 45 hours was still really quite high. I mean, normally for most of our cases, by 50 hours, the level has been negative for at least 24 hours. So this is very unusual. So they restarted the standard dose and continued it for the next 10 hospital days. So this was a pretty significant liver injury here, into the thousands, 8,000 on the liver tests, but the patient fully recovered. This was not using a higher dose. So this was raising some concerns. So another retrospective study was done in 2009. They looked at cases that really had all these characteristics, that the antidote is given within 8 hours, so that should prevent the toxicity, that they were in the toxic range, and that they had normal liver functions when they came in. And they found 77 patients that met all of these criteria, and 7 of the patients developed hepatotoxicity. That's nearly 10%. So they concluded that the standard form of IV N-acetylcysteine might be suboptimal, even when it's given early in patients who are showing no signs of toxicity. So risk factors that they looked at, if the acetaminophen ingestion is massive, or you have massive levels, persistently high levels, then you should take a very a tailored approach. It may be warranted to give a higher dose in these situations to contend with these really high and persistently high levels. So there were some other studies that have looked at this, and this study looked at 770 patients. The antidote was given within 24 hours. Now, this is the nomogram that we've been talking about. This is the 150 line. So they have a 100 line, 150 line, 200, 300, and 600. So as you can see, there was the square dots are significant liver damage. So you almost might conclude that, well, this nomogram doesn't work very well. And I think that could be a one conclusion that you could draw. But some of these patients actually were coming in with liver damage right when they got in the door. So when they excluded all those patients who came in with liver damage, so their presentation was normal in terms of their liver function, and then they were treated within 8 hours of using the antidote. So lower levels, you were seeing very little liver toxicity. So the threshold for seeing significant effects was at the 200 to 300 line. So again, we're seeing a problem somewhere around the 300 line, and that the higher you go on the level, the more toxicity you could expect. So how should we target this problem? So a few years later, a study came out of Australia that kind of looked at increasing the N-acetylcysteine dose. So this study looked at extended release acetaminophen. So this is kind of a perfect storm for an overdose, because you don't have all of the medication absorbed right away. It's going to be absorbed over a prolonged period of time. And if you take a large amount of it, you could end up with a very, very high level that lasts for a long time. And the standard dose of N-acetylcysteine that you see here, they start the third bag at about 5 or 6 hours. It's the lowest dose of the 3-bag procedure. But if you look at these overdoses, you're seeing really, really high levels persisting well after 4 to 6 to 8 hours. I mean, some of these levels are very high even at 24 hours. And the larger or the more that you take, the more problem that you're going to have. So this is kind of the perfect storm. And this is where they really wanted to look to see if a higher dose was going to help. So what they were doing on these cases was doubling the dose of the third bag. And basically they doubled that dose, and they just continue it, the standard dose and the double dose, for as long as the acetaminophen is elevated and as long as the liver functions are still abnormal. So these patients got started early. They all, over half of them received very prolonged courses of N-acetylcysteine, whether standard or higher dose. And 24% of them got this extra dose. So what did they find? Well, they looked at, whether the extra dose helps. So this line here at 1, that means they're comparing standard to higher dose. So if it's a 1, if your dot appears at 1, that means there's no difference. And if it spans the 1, that means there's no difference. So if you're clearly above 1, that means you're at risk for liver toxicity. If you're well under 1, then you have less risk. So what did they find? So time to acetaminophen or to N-acetylcysteine dosing. Well, if you wait too long, you're going to be at risk. Also, if your level is very high, you're going to be at risk. Now, charcoal, GI decontamination, did that make a difference? No, it did not make a difference. And then how about the extra bag, the extra double dose? No, it doesn't make a difference. That was this study. The same group did a study in regular release acetaminophen. So this is acetaminophen that should be absorbing rapidly. They had 200 patients with suspected massive ingestions. 43 of the patients that had really high levels got this double dose, this double bag. And this again is the standard dosing, and it's the third bag that gets doubled. So these are the outcomes on the two: higher N-acetylcysteine dosing versus standard dosing. And what did they find? They found that giving the higher dose did decrease the risk of hepatotoxicity. And when they adjusted this for how high the level was and when the antidote was given, the benefit held up. So now we've got, a couple of studies, one showing benefit, one didn't. So it was at this time when we started thinking about that this is kind of what we needed to do. And we decided to go with the 300 microgram per mil line to decide whether to give the higher dose or not. Now, if you're below the 150 line and your LFTs are normal, you don't need anything. If you have abnormal LFTs, even though you're below the 150 line, you should still get N-acetylcysteine. If you're in between the two lines, between 150 and 300, then and your liver functions are normal, we recommend standard dosing. However, if you have any sign of liver dysfunction in between these two lines, if that's where your level is, we consider that higher risk and would use a higher dose. So there's been some other studies since then that have come out. So what we were doing was looking for what the proper dose of this higher dose should be. So this is a study that looked at using a higher dose of N-acetylcysteine. So what they did was they compared standard dosing to this higher dose, which is 20 milligrams per kilogram per hour. Now, they weren't doing this study for massive ingestions. They were doing it for low-risk patients. But we looked at this to see if this was going to be safe and effective. And in this study, this involved thousands of patients. So we've got safety and efficacy here using a higher dose because we wanted to make sure it was safe and effective compared to the standard procedure. And that's what this study found. It was just as effective as the standard dosing. And it actually, in this study, there was less adverse effects with it. However, it was probably due to a slower rate of infusion on the loading dose. So also since then, there's been a couple of studies that have looked at higher dose. This is a study that looked at something similar to what we're doing, using this higher dose continuously over 24 hours or more after the loading dose. So in this study, they excluded anybody who had liver dysfunction on arrival, and they only included patients who got their N-acetylcysteine started after 8 hours. So these are the highest risk patients. So 23 patients received standard N-acetylcysteine, 66 got this longer, higher infusion. And what did they find? Well, they found that the two groups that they collected were very similar. So we've got two similar groups. and they found that giving this higher rate of continuous infusion had a decreased chance of developing liver toxicity compared to the standard IV N-acetylcysteine. So great, we have now 2 out of 3 studies that are showing benefit. However, another study came out at the same time, and this study looked at doubling the third bag. This is a larger study. It's more robust. They compared standard dose to this doubling of the third bag. They collected cases that were similar, trying to make a fair comparison here. The only differences were that the high dose N-acetylcysteine group, their time of ingestion was a little bit earlier than the standard dosing, but that would confer possibly some advantage. But the treatment still within 8 hours was similar in both groups. There was a little bit earlier treatment in the high dose doubling the bag group. But again, that would possibly confer some benefit or advantage. What did they find? So this, when you're treated within 8 hours, each of these groups had 1 case of hepatotoxicity. If it was after 8 hours, you had a lot more. So that's to be expected. So when they adjusted, when they looked at different parameters, but and including being treated within 8 hours, being treated within 8 hours, that was the biggest advantage. Using high dose N-acetylcysteine compared to standard, again, we're at crossing the 1 line. There's no advantage between these 2 treatments. So this study is showing no advantage. And when they adjusted for all those factors that we like to adjust for, whether there was liver dysfunction on presentation, whether they got it within 8 hours, there was just no benefit to doubling that bag. So now we're kind of at a point where half the cases are showing studies are showing some benefit to this higher dosing. Some are showing benefit, and half the cases are not showing benefit. So we're kind of still left at a point of, well, we're not sure. But this is what we're currently recommending here at our Poison Center. We're using either the standard protocol, which is the 3 bag that's been used for the last 20 years, or we're doing a modified SNAP protocol where we use the same loading dose, but we give a higher dose over 24 hours. And this is our tool to decide whether anybody's going to get the higher dose or not. So the 300 line, if you're above that line, that's where we're recommending the higher dose. The other lines, if you're between 150 and 300, if you've got liver problems at that point, we're recommending that higher dose. So this is what we're doing now. This is kind of a summary of the 2 methods. We've provided a lot of information to hospitals to make sure this gets done safely. So this is the standard recommendation. It's all based on weight. There's volumes for the 3 bags. And we've made sure that the volumes that we're giving and the concentrations are not too high. So we've really been focusing on the safety of what we're doing here. And we do send out this sort of information when hospitals call us to make sure that they're giving the right dose and the right volume for the right time, because it's really crucial to be safe here. There have been errors in the past of giving too much N-acetylcysteine by accident or on accident, and there have been some fatalities with that. So there's a real focus on safety, because we are not sure whether this is going to be beneficial or not. So we have a fax that we provide people. We did a talk through the WSPA, through the pharmacy associations, to kind of explain what was happening. And this was in 2020, right when the pandemic was happening. And we did a webinar, presented this topic. We got our staff trained on the procedure. And then in 2021, I started partnering with Washington State University to kind of look very closely at the outcomes on this higher dosing. All right, so that's what I have for you. And I think we've got some questions in the chat, I hope. But that's what I have. And thank you, Justin, for letting me present.
Sure, and thank you, Curtis, for sharing your time and your expertise with us today. If anyone has a final question, try and get it into the Whova chat Q&A as soon as you can. We'll probably have at least a few more seconds here. Did you take a look at the chat in Zoom there, Curtis, and see?
Yeah, I'm looking at that. So there's one question: is acetaminophen the most commonly used medication for overdose in use besides fentanyl? Well, I would hope that we're not seeing as many fentanyl overdoses as we are acetaminophen. Acetaminophen is still very common in young people because I think it's because it's over the counter, it's readily available. I think by and large, people still don't realize that there's toxicity with it. I mean, for fentanyl, we have an antidote, naloxone, and we have an antidote for acetaminophen. But I think that the problems really with the fentanyl, I think, really go beyond what we're seeing with acetaminophen. They're very, very different problems. We know very, very well that overdoses are going to happen. I think acetaminophen is like this hidden danger. People don't realize how toxic it is. I think everybody realizes fentanyl is, but so it is one of our more common overdoses in the young people. Yes. So there's another question: what can you do to inform loved ones and friends of the danger of Tylenol overdose? Well, I mean, prevention is the key. I mean, certainly attending this session is a good step forward. While this talk did not focus on maybe that people don't understand that acetaminophen can be toxic, I think that there's a lot of resources on the internet that will highlight this. I believe all the bottles have warnings on them. Keeping it away from kids. Think of it as a loaded gun. Lock it up. So also, do we frequently get calls at the Washington Poison Center for acetaminophen overdose? So yeah, that gets back to the data that I was showing. It is one of our more common calls. We get thousands of these calls per year, probably 3 or 4 every single day that are at hospital, and maybe about 30 to 40% of those require antidote. So in terms of the really massive ingestions, since we've been looking at that, maybe about 10% of the cases kind of qualify to get the higher dose. So it's not necessarily an everyday thing to get this higher dose to see a really massive level, but it's certainly every week we get a few. So maybe I did a good job here, Justin. We don't have a lot of questions in the chat.
So I think we're asking a lot of this, is if someone were to just read the description of your session and not be able to attend today, what would be the kind of one big takeaway you would hope that they were able to realize?
I think that poison centers are the place to go. I mean, we have the microscope on overdoses. They all get funneled, or many of them get funneled towards us. And that the development of the antidote for acetaminophen. This was brought to you by a lot of people at the poison centers. This has been our focus for 50 or 60 years. And, you know, certainly there are a lot of resources on the internet, but I think actually talking with a person who really is immersed in the problem is really going to be helpful. And that would be the one big takeaway. Call us about the cases. If you think you have you know, a case, you know, call us. We can really shorten the time for you to get your answer, because we deal with this every single day. You know, a few, you know, a case or two every day where we're using the antidote. A few cases every week we're using the high dose. So we are fully ready to answer your question.
Excellent. Well, I think that'll wrap us up. Again, Dr. Elko, I really appreciate you you lending your expertise to us today. And for the participants, thanks for stopping in, and I hope you enjoy the rest of the series. There's a lot of other exciting sessions today, so we hope to see you there. And thanks again.
Thank you.